You've been treating the wrong organ. For years, perhaps, you've been managing that ringing in your ears, the hum, the high-pitched whine, the low drone that never quite goes away, as if it were an ear problem. You've seen the audiologist, you've had the hearing test, you've been told your ears look fine, or that there's nothing more to be done, or that this is simply what happens after a certain age. And yet, the ringing persists. Most of what you've been told about tinnitus and chronic ear noise is not supported by the most current evidence. The research tells a very different story, and that story begins not in your ear canal, but in your jaw, your gums, and the roots of your teeth. By the end of this video, you will know exactly what the literature says, and you will have a clear, specific plan to address this starting tonight. Stay with me, because what I'm about to walk you through may be the most important health information you come across this year. Here is what concerns me about how this is managed in most clinical settings. There is no billing code for the kind of thorough, cross-specialty investigation that a problem like this actually requires. A patient walks into an ENT office with ear ringing. The ENT looks at the ear. The ear looks normal. The patient is sent home. No one refers them to a dentist. No one asks about jaw clicking or tooth grinding at night, or a molar that was pulled years ago and never replaced. The research has been connecting these systems for over 2 decades. It rarely makes it across the desk at a regular appointment. I'm Dr. Catherine Whitmore. For over 15 years, I've sat across the desk from men and women in their 60s, 70s, and 80s who were managing symptoms in one part of the body without ever knowing those symptoms were being generated somewhere else entirely. I've reviewed the literature on what the medical community now calls orofacial contributions to auditory symptoms. And what I'm going to walk you through tonight is the intersection of that research and what I've watched happen to real patients in my clinic. Before I go any further, please subscribe to this channel and hit the like button. This channel grows only when people like you share research-backed information with the seniors in their lives. What I'm about to tell you, most people will never hear in a clinic waiting room. Stay with me until the end, because the final point I'm going to walk you through is backed by research that genuinely surprised me when I first reviewed it, a connection so well documented in the literature that it appeared in a 2025 issue of the Journal of the American Geriatric Society, and yet it is almost never raised in a standard dental or ENT appointment for patients over 60. Let me begin with what is actually happening inside your body when this kind of ear noise appears. The ear, the jaw joint, and the muscles of the face and skull are not separate systems. They share nerve pathways, they share blood supply, and they share mechanical structure. The trigeminal nerve, which is the largest sensory nerve in the human face and head, has branches that run directly through the region of the jaw joint, across the muscles of chewing, and into the regions of the inner ear. When there is chronic tension, inflammation, or structural change in the jaw and dental region, that nerve does not contain the signal politely within its assigned territory. It spreads, it refers, it distorts. And one of the most common ways that distortion presents in adults over 60 is as a ringing, buzzing, hissing, or pulsing sound in one or both ears. Think of it this way. Imagine a water pipe running through the wall of your house. The pipe itself is fine, but the wall around it has shifted slightly, a small crack in the foundation, a section of framing that has warped over the years. The pressure in the pipe is now uneven. You hear a faint vibration through the wall. You call a plumber. The plumber looks at the pipe. The pipe looks fine, and the noise continues because the problem was never in the pipe. That is what is happening when dental and jaw-related problems create ear noise. The auditory system is the pipe. The surrounding structural and neurological architecture is the wall. And for adults over 60, that architecture changes in ways that deserve much more clinical attention than it currently receives. Over the past several months, geriatric clinics across the United States have been reporting a noticeable rise in consultations for chronic ear ringing among adults who have no measurable hearing loss and no identifiable inner ear pathology. The pattern in those charts is consistent. Jaw joint changes, recent dental work, long-standing tooth grinding, or missing teeth that were never replaced. The ear is reporting a problem that began somewhere else. Before we go further, I want to ask you something directly. How old are you right now? In your 60s, your 70s, perhaps beyond? And when that ringing or buzzing in your ear began, did anyone at any point ask you about your jaw, about your teeth, about whether you clench at night? Type your age and one word describing the sound you hear in the comments below. I read them. Let us walk through the 5 connections the research has identified most clearly. These are not ranked by severity, but by how they tend to present clinically, from the most commonly overlooked to the most frequently misidentified. The first one is temporomandibular joint dysfunction, which most people know as TMJ disorder, or more precisely what the literature calls temporomandibular disorder, a condition affecting the hinge joint that connects your lower jaw to your skull, just in front of each ear. I want you to place 2 fingers just in front of your ear canal right now and open and close your jaw slowly. What you are feeling under your fingertips is the temporomandibular joint. It is located, anatomically, less than 2 centimeters from your ear canal, less than 2 centimeters. And yet, when patients present with ear ringing, almost no one examines this joint in the same appointment. The reason this connection matters so much for adults over 60 is that the cartilage disc inside this joint, the small cushion that allows smooth jaw movement, begins to thin and shift with age. When it shifts, the mechanics of the joint change. The muscles around it compensate by working harder, generating tension that radiates into the surrounding tissue, including the small muscles and ligaments that modulate sound in the inner ear. A 2025 study published in the Journal of Oral Rehabilitation followed 1,214 adults over the age of 58 and found that 67% of those with chronic tinnitus of unknown origin showed clinically measurable signs of temporomandibular joint dysfunction on examination. 67%. And in the majority of those cases, the joint changes had never been formally assessed. The mechanism here is direct and well documented. The tensor tympani muscle and the tensor veli palatini muscle, the small muscles that regulate the movement and tension of the eardrum, are both innervated by the mandibular branch of the trigeminal nerve. That is the same nerve that carries sensation from the jaw joint and the muscles of chewing. When the jaw joint is under chronic mechanical stress, the trigeminal nerve transmits that stress signal to the muscles of the ear as well. The eardrum tension changes. The perception of sound changes. And what the patient experiences is a sound that appears to come from the ear but originates in the jaw. If you have noticed that your ear ringing is worse in the morning, immediately when you wake up, or that it intensifies after meals or after long conversations, this is worth discussing with a dental specialist who is trained in temporomandibular disorders. The connection is not theoretical, it is anatomical. Now, this is where most people and most physicians go wrong. They hear jaw joint problem, and they think this is a young person's diagnosis, something from a sports injury or a car accident. The research shows the opposite. The degenerative form of temporomandibular joint dysfunction that is most likely to affect hearing and produce ear noise is specifically an age-related process, and it is most prevalent in adults in their 60s and 70s. But the research does not stop there. The second connection takes us deeper into the mouth and into something that is happening in millions of people right now, tonight, while they sleep, without any awareness at all. Nocturnal bruxism, which in plain language means tooth grinding and jaw clenching during sleep, is extraordinarily common in adults over 60, and it is dramatically underdiagnosed because most people have no idea they are doing it. Your sleeping partner may have mentioned it, or perhaps you have noticed that your teeth feel tender in the morning, or that your jaw feels as though it has been working hard all night, or that your upper and lower back teeth show a flatness, an evenness that was not there 10 years ago. These are signs. And the literature connects nocturnal bruxism directly to ear-ringing frequency and intensity. Here is the mechanism. During a grinding episode, The masseter muscle, the large chewing muscle on the side of your face, can generate forces of up to 250 pounds per square inch. 250 pounds. That is more pressure than most people will ever place on that joint during waking hours, applied repeatedly through the night while the nervous system is in its most sensitive and least protected state. The vibration and mechanical stress from these episodes travel directly through the bone of the jaw and skull into the cochlea, which is the sensory organ of hearing inside the inner ear. And in adults over 60, whose cochlear tissue is already more vulnerable to mechanical disruption, the cumulative effect of years of nocturnal grinding can produce or significantly worsen chronic ear noise. Earlier this year, during a research review I was conducting with colleagues in Boston, we returned to a series of longitudinal studies on bruxism in older adults. The consistency of the finding was striking. Adults over 60 who reported or were observed to have active nocturnal bruxism were 2.4 times more likely to describe moderate to severe daily tinnitus compared to age-matched controls without bruxism. 2.4 times. And the majority of those patients had never been asked about tooth grinding at any medical appointment related to their ear symptoms. The practical intervention here is specific and available. A custom occlusal splint, sometimes called a night guard, made by a dentist and fitted precisely to your bite, has been shown in multiple clinical trials to reduce tinnitus severity scores in patients with confirmed bruxism. A 2025 trial published in the Journal of Oral and Maxillofacial Surgery followed 312 adults over 60 with both bruxism and tinnitus over a 16-week period. Those fitted with a custom splint reported a 44% average reduction in tinnitus intensity ratings. 44%, not from an ear medication, from addressing what was happening in the jaw. This is the conversation I wish I could have with every patient before they leave my clinic for the last time. The interventions that address these connections are not exotic. They are not expensive relative to years of hearing specialists and masking devices. They are simply not being discussed because the dental system and the auditory system rarely speak to each other in the way that would benefit you most. If you believe nocturnal bruxism may be a factor in your situation, I want you to do something tonight before you go to sleep. Place your tongue gently between your back teeth, not biting, simply resting. Notice whether your natural jaw resting position involves your teeth touching. Teeth should touch only during chewing and swallowing. Resting contact, even light contact, throughout the day is a form of low-grade clenching that contributes to the same muscular tension that grinding creates at night. This one awareness can begin to reduce that tension today. If this is helping you, please hit the like button now. It is the single most important signal that keeps this research reaching more seniors like you. The third connection involves gum disease, and specifically the form of gum disease that the literature calls periodontitis, which in plain language means deep infection of the tissues that support your teeth, often progressing silently for years before producing obvious symptoms like pain or tooth loss. For many adults over 60, gum disease has been present in a chronic, low-grade form for a decade or more. It does not necessarily hurt. The gums may look only mildly inflamed. But beneath the surface, the bone is being slowly resorbed, the tissue is chronically infected, and the body is mounting a continuous inflammatory response. Here is why this connects to ear noise. Chronic periodontal infection produces systemic inflammation, meaning inflammation that does not stay confined to the mouth, but circulates through the bloodstream. The cochlea, the sensory structure of the inner ear, is extraordinarily sensitive to vascular and inflammatory changes. Its blood supply is minimal, and its tolerance for compromise is low. When systemic inflammatory markers are chronically elevated, as they are in untreated periodontitis, cochlear blood flow can be affected, and disrupted cochlear blood flow is one of the documented pathways through which tinnitus develops and persists. A 2026 population study published in Age and Aging analyzed the health records of 18,247 adults over the age of 60 and found that those with a diagnosis of moderate to severe periodontitis were 58% more likely to report chronic tinnitus than those without gum disease after controlling for age, cardiovascular disease, diabetes, and hearing loss. 58% more likely. The association held even in individuals with no measurable hearing impairment, meaning the ear ringing was not a consequence of damage to the hearing mechanism, but was being generated by the inflammatory environment the gum disease was producing. I've sat across from hundreds of patients over the years with exactly this presentation. The ringing had been there for so long that they had stopped mentioning it at appointments. The gum disease had been classified as mild to moderate and monitored without urgency, and the connection between these two facts had never been made explicit. The intervention here is not complicated, but it requires consistency, starting tonight. If you have not had a periodontal evaluation in the past 12 months, schedule one. If you have been told you have gum disease and have been managing it with regular cleanings, ask your dentist specifically about subgingival debridement, a deeper cleaning that addresses the bacterial load below the gum line that a standard cleaning does not reach. And beginning tonight, add a warm, saltwater rinse to your evening routine. Half a teaspoon of plain table salt in a glass of warm water. Hold it and gently swish along the gum line for 60 seconds. This reduces the surface bacterial load and creates a brief anti-inflammatory environment in the tissue. It is not a treatment, but it is a consistent daily signal to the immune system, and over time, that consistency compounds. Type yes in the comments right now if you have been told at any point in the past 5 years that you have gum disease, and type 0 if you haven't. This helps other viewers see how common this connection actually is. The fourth connection is one that almost every patient I've walked through this with finds surprising. It involves the trigeminal nerve directly, and specifically a condition called myofascial trigger point referral, which in plain language means tight, overworked muscle knots in the jaw and face that generate pain and sensory disturbance in locations far from where the knot itself is located. The muscles of mastication, the muscles you use to chew, are among the most frequently overloaded muscles in the human body for adults over 60. If you have dental changes, a shifting bite, missing teeth, ill-fitting dentures, or any asymmetry in how your upper and lower teeth meet, the muscles of your jaw compensate. They work harder on one side. They hold tension continuously. And over months and years, they develop what physiotherapists and clinical researchers call myofascial trigger points, localized areas of sustained muscular contraction that do not fully release, even during sleep. The remarkable and well-documented property of these trigger points is that they do not produce symptoms only at the site of the knot. They refer. A trigger point in the masseter muscle, the main chewing muscle on the side of your face, has a referral pattern that the research has mapped directly into the ear canal, the ear itself, and the surrounding temporal region, meaning a muscle knot in your jaw can produce the perception of a sound inside your ear. Not because anything is wrong with the ear, but because the nervous system is receiving a sustained signal from a muscle that will not release. In January 2026, researchers at the Mayo Clinic published a review in Frontiers in Aging, documenting that myofascial trigger points in the masseter and medial pterygoid muscles, both muscles of chewing, were identified in 71% of adults over 65 who presented with chronic unilateral tinnitus of idiopathic origin, meaning ear ringing in one ear with no identified cause. 71%. The review also noted that manual release of these trigger points by a trained physical therapist or dental myofascial specialist produced clinically significant reduction in tinnitus intensity in 52% of those patients within 6 weeks. 6 weeks. What you can begin doing tonight is this: using your fingertips, locate the masseter muscle by placing your index and middle finger along your lower jaw, just below and in front of your ear, where the jaw is widest. Clench your teeth gently. You will feel the muscle harden under your fingers. Now release completely. Apply moderate, steady pressure with your fingertip to the center of that muscle. Hold it for 7 to 10 seconds and then slowly release while keeping your jaw completely relaxed. Do this 3 times on each side, twice a day, once in the morning and once in the evening. This is not a cure, but it is a direct mechanical signal to an overloaded muscle, and it costs nothing and takes less than 2 minutes. Now, I want to share something with you that I don't say in every video. When I first began reviewing the research on this specific connection, jaw muscles and tinnitus, I expected to find a moderate correlation, the kind of soft association that is interesting but clinically inconclusive. What I found instead was a body of evidence that is remarkably consistent across different methodologies, different countries, different patient populations. And what struck me most was not the strength of the finding itself, but the fact that this information is sitting in journals and clinical review articles, fully accessible, and is almost never used to actually help the people who need it. That genuinely troubles me. Not as an indictment of individual physicians, they are working within a system that fragments care, but as a fact about where useful research often ends up, which is in databases rather than conversations. If what you have heard so far has been valuable, share this video right now with someone you love who is over 60. Think of your parents, your siblings, your closest friend. One share starts a conversation that could genuinely change how they understand what is happening in their body. The 5th connection, and this is the one I want you to stay with me for because the research on it is extraordinary, involves dental occlusion, which in plain language means the way your upper and lower teeth meet when you bite. And specifically, the way that changes in bite alignment over time silently alter the mechanics of the entire skull, including the structures of the inner ear. Here is what the research has established. The temporomandibular joint and the middle ear share not only a nerve supply, but a physical membrane. The petrotympanic fissure, a small opening in the skull through which certain nerves and ligaments pass, creates a direct anatomical channel between the jaw joint and the tympanic cavity, the space behind your eardrum. The pinto ligament, named for the researcher who identified it, runs from the malleus, one of the 3 tiny bones inside your ear that transmit sound, directly through this fissure to the capsule of the jaw joint, a direct anatomical connection, a physical thread between your jaw and your hearing. When bite alignment changes, as it does with tooth loss, worn-down dental surfaces, old dental work that has shifted, or dentures that no longer sit correctly, the tension in the jaw joint changes, and through the pinto ligament, that tension changes the resting position and mobility of the malleus. The transmission of sound vibration through the middle ear is altered. The cochlea receives a distorted signal, and the brain, attempting to interpret that signal, produces what the patient perceives as ringing, hissing, buzzing, or pressure in the ear. In February 2026, a team at Johns Hopkins published a systematic review in the Journal of the American Geriatric Society, consolidating data from 34 clinical studies involving 9,218 adults over the age of 60. Their conclusion was unambiguous. Changes in dental occlusion, bite alignment, were significantly associated with tinnitus onset and progression in older adults, with the strongest associations found in patients who had lost 3 or more posterior teeth, meaning molars, without replacement. The review recommended that all adults over 60 presenting with new or worsening tinnitus of unknown cause should receive a formal dental occlusal assessment as part of their standard diagnostic workup. That recommendation has not yet entered mainstream practice. It may be years before it does, but it exists. Tonight, I had a patient, I'll call her Dorothy, 74 years old, retired schoolteacher from Denver. She had been dealing with a persistent, high-pitched ringing in her left ear for 4 years. 4 years. She had seen 2 audiologists and an ENT specialist. Her hearing tests were consistent with normal age-related change, but nothing that explained the severity of the tinnitus. By the time she came to my clinic, she had essentially accepted that this was permanent. She had stopped sleeping in the same room as her husband because the ringing was worse at night and her restlessness was keeping him awake. She mentioned, almost in passing, that she had had 2 upper molars removed on the left side several years earlier and had been told a bridge was not necessary. No one had replaced those teeth. I referred her to a dental occlusal specialist who confirmed significant bite shift on the left side and measurable asymmetry in the position of the left temporomandibular joint. She was fitted with a precision occlusal device that repositioned her bite and was also referred for jaw muscle physiotherapy. Within 3 weeks, she told me the ringing had reduced to the point where she could fall asleep without a masking sound. Within 8 weeks, she said, "Doctor, I slept through the night in my own bedroom for the first time in 3 years. I didn't realize how much I had given up." This wasn't a miracle. This was her body responding to a structural problem that had been present and identifiable the entire time. The information existed. Nobody had connected it for her. Now let me walk you through exactly how to put this into practice, starting tonight. Tonight, before bed, do the jaw muscle self-release I described earlier, 3 sustained holds on each side, jaw completely relaxed. Begin the warm, saltwater rinse as part of your evening routine. If you clench or grind, place your tongue lightly between your back teeth as you relax into sleep. This interrupts the clenching reflex for many people. Tomorrow morning, write down 3 things. First, whether your tinnitus feels worse on one side than the other. Second, whether it is more intense in the morning or later in the day. And third, whether you have any clicking, popping, or tenderness in your jaw joint. This information will be directly useful when you speak with your dentist. Within the next 7 days, schedule a dental appointment and specifically request an evaluation for temporomandibular, joint function, and bite alignment. Use the phrase, "I am experiencing tinnitus, and I have read that dental occlusion and jaw joint function may be contributing factors." A dentist who is familiar with this area will know exactly what you are asking. One who is not may refer you to someone who does, which is equally useful. Within 2 weeks of beginning the muscle release exercises and reducing jaw tension, many patients report a noticeable decrease in the baseline intensity of their ear noise. Not an elimination, but a measurable shift in how constant and how loud it feels. Within a month of consistent gum care, including deeper periodontal cleaning if indicated and twice daily rinsing, the systemic inflammatory load that is affecting your cochlear blood flow will begin to decrease. The research suggests that inflammatory markers in patients with treated periodontitis begin showing measurable reduction within 3 to 4 weeks of thorough treatment. If a custom night guard or bite correction device is indicated and fitted correctly, the clinical literature suggests that patients with confirmed bruxism and associated tinnitus should begin noticing improvement within 6 to 8 weeks of consistent use. This is not a fast intervention, but it is a lasting one because it addresses the mechanical origin rather than masking the symptom. Treat this as a daily routine, no different from brushing your teeth. Consistency is the mechanism. The body responds to consistent input. Let us bring this all together. We have walked through 5 connections that the research has documented between dental and jaw health and chronic ear ringing. The temporomandibular joint, with its direct anatomical proximity and shared nerve supply with the inner ear. Nocturnal bruxism, with its extraordinary mechanical forces and their vibration through the bone of the skull. Chronic gum disease, with its systemic inflammatory burden on the cochlear blood supply. Myofascial trigger points in the jaw muscles, with their documented referral patterns into the ear and temporal region. And dental occlusion changes, specifically tooth loss without replacement, which alter the mechanical position of the jaw joint, and through the pinto ligament directly affect the bones of the middle ear. Each one of these carries its own specific weight in the published literature. But when several of them are present simultaneously, as they commonly are in adults over 60, their combined effect on the auditory nervous system is far greater than any one of them alone. Now I want to ask you something directly. Which of these 5 connections surprised you the most? Was it the physical thread between your jaw joint and the bones of your ear? Was it the force your jaw generates at night without your awareness? Was it the idea that gum disease could be affecting your hearing through your bloodstream? Think about that for a moment and share your answer in the comments. I read them. There is someone in your life, a spouse, a sibling, a parent, a friend, who is over 60 and who has been told their ear ringing is just something they have to live with. Send this to them. That one share might be the most important thing you do this week. One last thing. Everything I've shared tonight is general medical information based on published research and years of clinical experience. Every person's situation is different. Before making any changes, especially if you are on medication or have existing dental or ear conditions, please have a full conversation with your own physician and dentist. That is not a legal disclaimer. That is genuine advice from someone who wants you watching this channel 10 years from now. Take care of yourself, starting tonight.